This conference will now be recorded.
Yes, that it was. All right, got it, Nicole and Steve. Thank you. All right, so chapter 11, Principles of Pharmacology. So with pharmacology, it implies the fundamental knowledge of the medications that the EMT may assist or administer to a patient during an emergency. So there are medications that you guys are allowed to use to either assist or administer. When you're assisting, you might be contacting like medical control to assist with that before we start giving these certain medications, like nitroglycerin being one of them. So there are meds that we're going to be utilizing that'll be of benefit to the patient to help them become better. So in order to give a medication, we have to know the different rights of patient medication administration, along with that medication safety. Some of these medications that we can't administer will actually kill a patient if given in the wrong situation, which is why we need to know what we're going to be giving, how we're going to give it, how it's going to be administered based upon a route. Make sure it's the right patient, right time, right dosing. There's a lot to know with medications. Also with pharmacology, once you start learning more, the other medications like over-the-counter stuff that patients take or prescription meds will actually really assist you in finding out patient medical history, especially if they're unconscious. You'll be able to look at the medication and say, oh, they probably have this, this, and this, and you have something that you can go by. So medication administration is part of the competency with self-administered meds, peer-administered meds, and assist-administered medications to a patient. So with the emergency medications, we're going to see names, the effects, the actions of the medication, the indications and contraindications. We're also going to have complications of the med, routes of administration, side effects, interaction, and dosages for the medications administered. That's why it's so important to be able to understand all the different routes and how things work, so that way you can explain to a patient, if I give this, these side effects are expected to happen. So medications are an important intervention. It can definitely help treat these patients. For example, like aspirin and nitro, the platelet aggregator, and a nitrate for vasodilation. This will help oxygenate the cardiac muscle that we were talking about by dilating arteries to allow for better gas exchange at the cellular level. Medications may also alleviate pain and improve the patient's condition. So there are some medications in the New Hampshire scope of practice to help alleviate pain at the EMT level. And we have the ability to, administer PO being oral, PO Tylenol, and PO ibuprofen. So ambulances should be carrying water bottles on the ambulance to help with the administration of this. So there are some things we're going to do that are going to be oral meds within our scope of practice. Failure to administer medication safely and competently can lead to serious consequences for the patient, including death. So example would be a patient who has a blood pressure of 80/40, active chest pain, and you give them nitro and you bottom out their blood pressure to the point where they can't recuperate, then they go into cardiac arrest due to hypotension. So giving someone albuterol for a patient who's in congestive heart failure, causing them to flood even more into the lungs. That's why lung sounds are so important. So there's a lot of different avenues we can go with these medications as long as we're giving them in the right patient presentation. So as an EMT, you will administer meds. There are some that you are not going to be carrying in your drug box, but will help patients self-administer medications, like nitroglycerin, albuterol, MDI inhalers, things like that. You're going to ask patient about medication use. So you got to figure out what kind of medications they're on, and you're going to report patient information to hospital personnel. So it's essential that you have the knowledge and skills to administer or assist in administration of these meds. So how a medication works. So pharmacology is the science of a drug. A medication is a substance used to prevent or treat disease or relieve pain. So if we're going to prevent or treat a disease like COPD, we can administer albuterol to help bronchodilate a patient. If we have a person with acute coronary syndrome, we can start giving aspirin to make the platelets less sticky in the system to prevent any further clotting. Remember that aspirin is not a blood thinner, it is a platelet aggregator. And then we also have nitroglycerin as a nitrate that is used for vasodilation. So the pharmacodynamics is a process by which the medication works on the body. So I gave you a medication, pharmacology, science of the drug, nitro, classification being a nitrate, and the pharmacodynamics being how the medication works. As it goes into the system, it causes widespread vasodilation, allowing the vasculature to become bigger to allow more blood flow. But the side effect to that would be we're allowing more blood flow, things are getting bigger. That means that there's not as much pressure behind it, dropping our blood pressures. All right. So there are some side effects behind what we're going to be doing. Stand by 1 second here. So there are different types of receptors that are located throughout the body as well. These are sites on cells where medications or chemicals can bind and produce an effect. I'll give you an example of this in a second. So when a medication is given, they bind to these sites and either stimulate the receptor to produce an effect or block a receptor to prevent other chemicals or medications from binding. An example of that would be someone who is on opiates and they're given Narcan. Narcan binds that receptor to not allow any more of that opiate, heroin, things like that, to get onto that receptor to cause our opiate receptors that we have in the body to cause our decreased respirations or alter mental status, things like that. That's why we're going to be giving these medications to help attack to these receptors. The medication to either increase or decrease normal function of the body. So like we talked about nitroglycerin being a nitrate that has vasodilation, that can decrease a normal function by not allowing our heart to have this pressure behind the arteries to give us a higher blood pressure because we're dilating. Does that make sense?
Yes.
Perfect. All right, awesome. So let's talk about how the medications work with an agonist. An agonist causes stimulation of a receptor. So a medication that causes stimulation, an antagonist is a medication that binds to a receptor or blocks another medication or chemical from attaching. All right. So a medication that we can use that would be an antagonist would be naloxone, Narcan. The dose is the amount of medication that is given, which depends on patient's weight, age, and desired action of a med. So what we're going to be administering as far as the EMT level goes, as far as patient's age, there's not much we're going to really deal with age-wise other than epinephrine or age where they cannot receive a medication like nitrates to a pediatric. But we do have the ability of administration for epinephrine for a pediatric, and our dosing would be a smaller dose than it would be for an adult. So that age would be very dependent on the size of the patient, also patient weight as well. And then our desired action. If we do not give enough, then we're not going to get the desired action of what we're looking for. Our protocols for Tylenol, they want us to give 1,000 milligrams. We only gave 500. We may not get that desired action of pain relief that we're looking for. Right? We're also going to be giving NSAIDs like ibuprofen, and our max dose is 400 milligrams, one tablet. We cut it in half, or we have two 200 milligram tablets in our pouch. Are we really going to get that anti-inflammatory effect that we're looking for with that NSAID if you only give half a dose? So what is our desired action of the med? The action is a therapeutic effect. Okay, the therapeutic effect is the medication that the medication is expected to have on the body. So what do we expect it to happen? We give something for pain, we expect the pain to be reduced. If we give nitro, we expect the chest pain to decrease. If we give oxygen, we expect our oximetry levels to go up higher and help the patient breathe better. If we give albuterol, we expect bronchodilation to allow better gas exchange. So these are the desired effects, the action or the therapeutic effect that we're going to see. This is also referred to as a desired or intended effect as well. Indications or reasons or conditions for when a particular medication is given. So you're going to look at your protocols. You're going to say, okay, you have a patient respiratory distress. These are the indications for this. Shortness of breath, wheezing, things like that would be used for albuterol, MDI inhaler, oxygen. If we have a patient who has acute coronary system or chest pain, then we're going to be giving them aspirin, assist with nitro, oxygen. So those are our indications and reasons on why we give a patient a med. A contraindication is why we cannot. So situations which a medication would either harm the patient or have no positive effect. If I have a patient with chest pain and I give them Narcan, there's no desired effect for that. There's no positive effect by giving someone Narcan that has chest pain, unless they have taken opiates, right? There's no desired effect of giving a chest pain albuterol. All that's going to do is increase the heart rate and probably upset the heart even more, right? But if I got a patient who is in respiratory distress, COPD exacerbation, I'm not going to give them aspirin because we're not having our clotting issue, right? They have a COPD issue. We're trying to fix that with dilators instead, right? The absolute contraindication situations in which a medication should never be given if the contraindication is present, and that would be like an allergy to a med. So if I said to Joy, can I give you aspirin? And she says, no, I'm allergic to it. I cannot have aspirin at all. And I give it to her anyways. She takes it and then goes into cardiac arrest. I am held liable. I have now given a patient something they're allergic to. So now you can kind of see where this sample history that we talked about, signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading to illness or injury. These are important questions you need to get answered before we start giving meds. If you give the patient the wrong med at the wrong time, or they have an allergy to a med, right, that's going to cause a patient to become worse, okay? And by that, we are now doing harm to a patient, right? How do you prove negligence? That's one of them, one of the four, providing harm, right? So Joy mentioned everybody that's in the group. I can't have oral NSAIDs due to the bariatric surgery. She can't have those, right? So Joy, what would happen if you got them? If you had an oral NSAID, what would happen to you? If you want to talk about it. Or type it out if you'd like as well. But as you can see, it's not an allergy for her, but she can't get them. I'll continue on. If it pops up, I'll read it off for you guys as well. So decrease the size of the stomach tissues is a greater risk for ulcers. Stomach after bariatric surgeries are more prone to developing ulcers, as Condren has said, right? So this is why she can't get it. All right, these are questions you need to be asking these patients to make sure before we start administering these medications. Any med, from paramedic down, we have to make sure we're asking these questions of the contraindications, their allergies, any kind of side effects, things like that. Some of the side effects would be unintended effects. These are effects that are undesirable but pose a little risk to a patient. And untoward effects are effects that can be harmful to the patient. All right, so let's talk about medication names. These are always the fun ones, right? Like Tylenol and acetaminophen, same thing, same name, just different trade name versus manufacturer name. So the generic name is a simple, clear, non-proprietary name. Example, ibuprofen, Tylenol, right? The trade name, the manufacturer's brand name would be like Tylenol versus acetaminophen, right? So you have the generic name, acetaminophen, the trade name being like Tylenol. Narcan versus naloxone. So generic names are not capitalized. Keep this in mind as well. Generic names not capitalized. Some medications would be like nitroglycerin, are called by the generic name more often than their trade name. The trade name is a brand name that manufacturers give to a drug, and you're going to have a capital letter that'll be capitalized, like Tylenol, Lasix. The trade names always begin with a capital letter. Okay, these are things you guys are going to see on your exams. And there are also other medications that are out there, or drugs that may have more than one trade name. Right. So again, look at your meds that are there. You may see a generic, you may see a trade name, you could have one or the other, or multiple. Prescription medications are drugs that are distributed only by pharmacists and require a physician's order. So a lot of patients take prescription meds. Prescription medications will actually help determine patients' medical history. Then you have OTC, or over-the-counter medications, which are drugs that may be purchased directly without a prescription. So anything you can buy over the counter. And some medications are actually behind the counter now because of other effects that they may have. Like Mucinex DM, you have to buy behind the counter now because of the DM effects. People are actually taking those to get high. So again, just over-the-counter meds, Tylenol being an over-the-counter med. But if a Tylenol is at a higher dose, let's say, 1,000 milligram tablet versus 500, those might be a prescription med versus over-the-counter. So there are some medications that are out there that could be over-the-counter, but they're given to in a higher dose, like Motrin can be administered in a higher dose if a physician writes a prescription for that. Other kind of drugs that are out there, recreational drugs like heroin, cocaine, meth, things like that. Herbal remedies, enhancement drugs, and vitamin supplements. So any medication that a patient takes can be pharmacologically active and can cause an effect. So ask patients about any and all medications or drugs they have taken. One of the big ones that comes to mind is erectile dysfunction meds. If a patient is on erectile dysfunction meds, and that can be male or female, or they could be on an ED medication for cardiac use. I've seen that as well. Especially I've seen that with a 17-year-old before who was on ED med female because she had a cardiac defect and she had to take erectile dysfunction medications to help. If you give a patient on erectile dysfunction meds that have taken them within the last 24 hours, and you give them nitrates, not only do you have the vasodilation from the ED med, but now you have more excessive vasodilation from nitro. And because of that, you can take out a patient's blood pressure and kill them. So it's very important to find out what medications are on and if they're compliant with those medications. And one of the questions you should ask with nitrates before administering nitroglycerin is, are you on any erectile dysfunction medications for any reason? Right? Routes of administration. Enteral medications enter the body through the digestive system, often in pill or liquid form, such as cough medicine. Medications may also be administered via the route, tend to be absorbed slowly, and are not commonly used in emergency settings. So one of the medications we do give that goes through the digestive system is going to be Tylenol and ibuprofen. Right? It takes a little bit longer to kick in, but it's better for pain than starting to pump these guys full of narcotics. Right? Maine has taken great strides in trying to combat the opiate crisis. New Hampshire is going to do this as well. But Maine has given IV intravenous Tylenol to the advanced EMT level and paramedic level currently, and New Hampshire is not far behind. Massachusetts has already had this for the paramedic level now for about a year. So we're starting to see these other medications come on board to the pre-hospital setting to help combat that opiate crisis. Parenteral medication enter the body by some other means, often in a liquid form administered through needles or syringes, right? So we're going to be utilizing these for patients at the EMT level, and two of these medications we administer, not necessarily IV, but intramuscular, are going to be epinephrine 1 to 1,000 and Narcan. Narcan right now for the EMT level, though, however, is intranasal. we're going to be putting a nasal atomizer as it atomizes going into the mucous membranes of the nasal cavity, right? So that's another liquid form of medication through needles or syringes. These absorb more quickly and often more predictable and measurable response. So we give somebody who is overdosed or on a narcotic opiate overdose, we look at decreased respirations, altered mental status, or unconscious, pinpoint pupils, our classic triad, looking at our toxidromes that we have in front of us, which are a series of events or indicators that would be a specific overdose. We give them Narcan. Remember, it's an antagonist, right? Attaches to the receptors to block anything else from happening. And by doing so, the patient tends to wake up more at a faster rate. Intranasal, though, however, is a little bit slower, but still a medication that works really well. But you may have to give a little bit more than you would if someone who's getting intramuscular or intravenous. Absorption is the process by which a medication travels through the body tissue into the bloodstream. So some common routes of administration would be PR, which is per rectal or per rectum, birectum. Frequently used with children and easy to administer and provides reliable absorption. Your rectum is very absorbent, right? And I can tell you there are college kids that have found this out by putting alcohol into their rectum and becoming very drunk very, very quickly. I've been called to this when I've worked on college campuses before, where people have put beer bottles there and started chugging away. They can get very drunk very quick to the point where they can actually pass out in alcohol intoxication. So a PR, again, very vascular, high absorption, works great for kids, especially like PR, acetaminophen. That works really well to reduce fevers. Other common routes would be oral, or as PO, that's another name for it. So you'll see me say PO versus oral. This is by mouth. Often use the medications for nausea, vomiting. So we do carry, there are medications at the higher levels called Zofran, which is like an oral dissolving tablet that we can administer. But, excuse me, there are medications that you guys are going to be assisting with, like nitroglycerin, which will be something called sublingual, which is still an oral med. It goes in the mouth but underneath the tongue. So it's called a sublingual administration. Anything by mouth enters the bloodstream through the digestive system. Usually takes as long as an hour for absorption to occur. The pros behind this, they're non-invasive. They're less expensive than a parenteral route. So IV medications or intramuscular meds, intranasal meds are more expensive than just buying something that's PO. The cons are unpredictability of the medication absorption. How long it's going to take? Is it going to work? Did we give enough medication? Absorption affected by an upset stomach or diarrhea. So again, if you are taking a PO medication, you have constant diarrhea or overosmosis of the colon, right? We're just pooping it out in a diarrhea form. The patient really going to be able to absorb that medication through the GI tract if it's just coming right back out again. So orally disintegrating tablets, which is ODTs, are put directly onto the tongue where they dissolve into the membranes of the tongue itself, through the skin that way, or through the tissue of the skin. So we do not have anything that's oral dissolving tablets at the EMT level, at least not yet. Wouldn't be surprised if Zofran came down to that level with an ODT at some point. Other routes of medication or common routes are IV into the vein, called intravenous, interosseous IO, which is into the bone. So we take a bone drill, we drill into the where the open area where the bone marrow is located. That's how we administer medications through IO. We have what they call a subcutaneous, which is beneath the skin, or SC. Intramuscular is IM, so into the muscle. We don't do a ton of IO injection. Again, this is going to be used for AEMT and higher, but this reaches the bloodstream, like I mentioned, like the bone marrow. It is a painful administration can be done for patients that are conscious. Usually the unstable patients where you can't get an IV within 90 seconds. If you can't find something in an unstable patient, then we usually put an IO in place. The reason why it's so painful with this is because we're injecting fluid into a cavity that doesn't expand. Like veins can expand, right? But bones cannot. So you have a lot of pressure inside the bone. So they've given advanced EMTs lidocaine to help numb the inside of the bone prior to administration, which is actually pretty good to have. Intramuscular injections, which is something that EMT level will be administering through EpiPens or what they call a ready check inject kit, where you'll be drawing up epinephrine 1 to 10,000 and 1 to 1,000 and administering the medication through intramuscular through the lateral thigh. As we inject it in, we'll go over a whole training on this in person. But as we inject it in, it does cause the fluid to go into the muscle area, which can be very painful at times, which is why you need to actually massage the area for the patient to help disperse the medication through the muscle. This will actually help it work a lot better as well. Subcutaneous is beneath the skin. One of the things you'll come in contact with subcutaneous in the field, there's really nothing at the paramedic level that we do subcutaneous anymore, but insulin is administered subcutaneous, right? So you may have a patient who takes insulin, and you take a look at their abdominal cavity, and a lot of times you'll find insulin injections around the umbilical area. You'll start seeing multiple bruising all over the place. And if you see that, just ask them, are you a diabetic? Do you take insulin? And they'll probably say, most likely say yes. All right. Inhalation, inhaled into the lungs. The inhalation ones that we're going to be utilizing are going to be oxygen. We're going to use inhalation on MDI inhalers. And then now with the new protocol set, which is above the National Registry, is inlining nebulized medications through CPAP, which is at the EMT level, both Maine and New Hampshire. So we have what they call Duoneb, which is 2 different medications. It's albuterol and ipratropium bromide. So you have a steroid along with a bronchodilator that are mixed together and to form 3 mLs of fluid that we're going to nebulize through aerosolization into a mask, and we're going to push it deep into the lungs. Oxygen also being an inhaled med. Sublingual under the tongue, that's going to be your nitrates at your level for nitroglycerin. Transcutaneous or transdermal through the skin. This is more advanced EMT paramedic with nitro paste. Then intranasal or into the nostril by the mucosal atomizer device, what they call a MAD device, MAD. That's the only medication we'll be administering intranasal at the EMT level is going to be naloxone, Narcan. With that, it does take a little bit longer for intranasal to actually kick in and work. But again, give it time. In the meantime, just ventilate your patient until they wake up. So as you can see here on the table, our route of administration and rates of absorption. Enteral, which would be sublingual, PRPO. Sublingual and rectal are very rapid. Remember I mentioned the vasculature and the smooth muscle of the rectum, right? It allows for quick absorption, all right? Same thing with sublingual in the tongue. It's very vascular underneath the tongue. That's why you have a rapid administration. But your PO by mouth, remember, it has to go into the GI tract. It'll take longer to kick in. All right, parenteral, IVIO is immediate. It's the same thing. It's just one goes into the bone, one goes into a vein. It's immediate response. Inhalation intranasal is a rapid response. Intramuscular is moderate, right? So epinephrine, it may take 3 to 5 minutes to kick in, maybe a little bit less. It could take a minute or 2. And then you have your subcutaneous and transcutaneous or transdermal medications that are very slow because those have to absorb either in the fatty tissue subcutaneous or in a transcutaneous through the skin through a transdermal administration. Why do you guys need to know transdermal? Because you're going to come in contact with patients and have transdermal patches on, whether it be a nitro patch, it could be a fentanyl patch. I've seen those before. I've actually been to a couple overdoses of those before with patients chewing on them to try to get high quickly. You're also going to have nicotine patches, nitro, like I said, nitro patches will be on. And you might come in contact with these patients. Lidocaine patches are very common. People have muscle pulls and spasms and things like that. So we do not touch any of these with our bare hands. We always make sure we have gloves on and make sure we wipe off the skin. Over there, we don't have any contact with that and then knocking ourselves out. So the form of medication usually dictates the route of administration. For example, a tablet or a spray cannot be given through a needle. The manufacturer chooses the form to ensure a proper route of administration and timing of the medication release into the bloodstream. This affects the target organs or body systems. These does have effects as well. Some basic forms would be tablets and capsules. We're going to see a lot of this out in the field, especially with patient administration, patient medications or own meds. Solutions and suspension medications, metered dose inhalers, MDIs, like your albuterol. Topical medications would be something like lidocaine patches, topical meds. Transcutaneous medications as well. Different gels, gases for inhalation. So you'll have patients that are on oxygen at home. So we're going to kind of go more on this in a little bit of detail with tablets and capsules. So capsules are gelatin shells filled with powdered or liquid medication. Most medications given by mouth are in a tablet form, however, or a capsule form. Capsules usually gelatin, which we talked about already. Tablets often contain other materials that are mixed with the medication and compressed. Remember that a medication that must be swallowed and digested provides a slower route of delivery and is less useful in an emergency. Solutions and suspensions. A solution is a liquid mixture of one or more substances that cannot be separated simply. Solutions can be given by almost any route, and when given by mouth, solutions may be absorbed from the stomach fairly quickly because this medication is already dissolved. Many solutions can also be given as an IV, IM, or subcutaneous injection. A suspension medication is a mixture of finely ground particles that are distributed evenly throughout a liquid by shaking or stirring, but do not dissolve. Suspensions separate if they stand or are filtered. It is important to shake or swirl a suspension before it is administered. These are usually administered by mouth, whether it be like an antibiotic or pediatric patient, or activated charcoal, which is one of the natural registry medications you need to be familiar with. Occasionally given rectal or applied directly through the skin, like calamine lotion. Another one may be also given intramuscular or subcutaneous, like hormone shots or vaccinations. All right, so metered dose inhaler. Metered dose inhalers, we do not carry those on the ambulance. However, patients who are asthmatic, COPDers, things like that, or if they have like pneumonia, they may be given this to kind of help them get through until they get better. They may have these. Metered dose inhalers are liquids or solids that are broken into small enough droplets or particles that may be inhaled. A spray canister directs such substance through the mouth and into the lungs and delivers the same amount of medication each time it is used. That's why it's called metered dose, right? So it delivers the same amount every single time. Often used for respiratory illness such as asthma or emphysema. So you'll see like COPD, asthma, pneumonia patients, they have this as well, administered by the hospital. For these to actually be administered, we want to make sure that if we're going to assist, we contact medical control at the EMT level. And then we want to make sure that we follow the instructions on the bottle. So if you take the red piece off, that inside canister actually does come out. You want to make sure you check the expiration date, make sure it's not expired. Right patient, right dose, right time. The full rights of the patient medication administration, which we'll be covering here shortly. As we administer these, we're going to shake it up. We're going to have the patients exhale all of their air. And as they breathe in, they're going to then depress the canister and they're going to hold their breath for, try to get it for about 10 seconds. This allows that medication to get deep into the lungs, into the alveoli, and also the bronchioles, and help with that bronchodilation. These are rescue inhalers. They are not designed for long-term use. So if patients are taking these and they don't get better, then they need to have some other form of medication administration that could be duonazole or albuterol, whether it be given by CPAP inline or asthmatics, where you need to give other medications to assist. Topical medications include lotions, creams, and ointments. At the EMT level, we do not administer any of these. They're not even within our scope of practice, which is interesting. For examples, applied to the skin surface and affect only that area. As an EMT, we don't apply any of these, but the patient can. Like Neosporin, calamine lotion, hydrocortisone. As crazy as this sounds, we do not carry any of this stuff, and it's not within our scope of practice to even administer. But if you took like a basic first aid class through the American Red Cross or American Heart, you can do all this stuff under Good Samaritan. But once we have that EMT license, we have a duty to act. They take it away. It doesn't make any sense to me, but that's how things just work out. Transcutaneous medications are designed to be absorbed through the skin, also referred to as a transdermal, so transcutaneously administered. Also, unlike topical medications, which affect only the intended site, many transdermal medications have a systemic whole body effect. As you can see here, transcutaneous medications. Some examples for this would be like nitro paste. And again, if this gets on your hand though, okay, it can actually make you start becoming lightheaded, like you're gonna pass out. All right, so you gotta be careful with that. Always have gloves on when you're touching these medications. And again, they may have a nitro patch, nitro paste. Imagine touching a fentanyl patch with your hands. Now you start getting transdermal fentanyl. All right, so be careful. If you touch a medication with your skin, you will absorb just like the patient does. So gels are semi-liquid, which administer in capsules through plastic tubes. Usually have the consistency of paste or creams, but are transparently clear. And one of the ones we're going to be administering in the field is not glucose tablets, but that's in the glucose 15 tube. That's oral glucose, and that's something that we would be utilizing or administering. So gases for inhalation, obviously outside the operating room, most commonly used is oxygen. We're not going to be getting any other gases in the back of the ambulance at the EMT level. All right, advanced EMTs and paramedics have nitrous oxide for pain management, but at the EMT level, right now, it's just going to be oxygen. It wouldn't surprise me if nitrous oxide came to the EMT level sometime in the future, because it's self-administered until they pass out, then it stops. So gases for inhalation neither solid nor liquid, usually delivered through a non-rebreathing mask or a nasal cannula for oxygen, and most often are given in the operating room for other medications that are going to be administered. The most common medication in gas form used is O2. So general steps in administering meds. These are the important things you need to know, and you will, I guarantee you that you will see this on your National Registry exam, along with any exam that I give you as well. Medications should be administered only under the authorization of medical control. Now, we have standing orders, okay? So oxygen, aspirin, epinephrine, these are all medications that are considered standing orders. The doctor already said you can do this without calling me. If you have any question or doubt, then obviously call med control. But there are other medications like nitroglycerin, which need medical control approval before administration. So with that, we need to follow the 6 rights of patient medication administration. So anytime you give a patient a med, they have to meet these 6 rights. If you do not, then this medication is not for them. All right, and these are the 6 rights of medication administration. Medication errors almost always result from failure to follow these 6 rights. You need to make sure that you have the right patient, the right medication, the right dose, the right route of administration, the right time to give it, and the right documentation behind it. If you cannot fully say that these 6 rights are being met, then do not give the medication. All right? Then something is not right. Then contact medical control and have a consultation and have a chat with your doctor. All right, the med control physician at the hospital. So medications that administered at the EMT level. And now keep in mind, this is national registry. Then we have our state and local protocols, which allows us to give a little bit more, right? So the unit may carry oxygen, oral glucose, activated charcoal, aspirin, epinephrine. The epinephrine at the EMT level is a 1 to 1,000 mixture, okay? We're going to be administering. This does not go intravenous, okay? This will actually kill somebody intravenous, but will actually help a patient at the right dosaging intramuscular. You may be given these medications only according to standing orders in a protocol or a direct order, which would be a verbal order over the phone talking to a physician. Over the years, EMTs have been allowed increasing responsibility to work with medication, which is a great thing. Because a lot of small towns, they don't have the availability of AEMTs and paramedics. So EMTs have to have a little bit more of a scope to be able to start treating these patients. Many departments have strict guidelines on when an EMT is allowed to administer a med. The circumstances are peer assisted administration. You administer a med to yourself or to your partner. Example, if you were exposed to a toxic agent. For the longest time, we carried what they call Mark 1 kits on the ambulance. And Mark 1 kits were 2 different medications inside that had 2-PAM and atropine, 2 medications that help with organophosphate overdose or poisoning. They were not designed to give to a patient, but to your partners only on the ambulance. They were there for you. So the state went out and bought them all. They were very expensive, and then they never replaced them. Just when I thought it would be quiet being here at the station. So if you assist exposed to a toxic agent, typically it's auto-injector form. Patient-assisted administration is when you assist the patient with his or her own medications. Examples would be like an MDI bronchodilator, like albuterol, an EpiPen auto-injector, or nitroglycerin. EMTs administered medications. EMT directly administers the medication to a patient. Examples of that would be oxygen, oral glucose, activated charcoal, nitro, aspirin. But again, if the patient may be severely confused or unable to understand the need for the med, right? So if they're confused, but they still need these medications, that's when you contact medical control and consult for them. Now, if the patient refuses to take a med, okay? So good question by the group. If the patient refuses to take a medication, try to convince them to take it, okay? Because remember, we are the medical professional trying to get them to take these meds as that patient advocate, okay? If they adamantly refuse, try contacting medical direction and talk with the physician and see if the physician can convince the patient. If the patient is adamant that they will not take the medication, then you document that in your narrative that the patient refused administration and that you did contact medical consultation as well. Pass the buck to a doctor, do everything you possibly can. If you feel that is a life or death medication, then you need to let them know that, okay? And then document. So the medication itself does not necessarily dictate whether you will be assisting with the administration or actually administering the drug. Medical control, state guidelines, and local protocols determine which medications an EMT in your system may administer. Refer to your local standards, local protocols, and listings of how an EMT can administer a med. So they mention like all these medications that are on here, but New Hampshire allows you to give a little bit more, like Tylenol, ibuprofen, Narcan. So there are other medications that you'll learn on different modules you'll be taking. Epinephrine through intramuscular injection that's not an auto injector. Because auto injectors they're like $600 a piece for the longest time, and services couldn't afford them. I don't blame them. But they could buy a vial of Epi and some needles for like $5, you know? So it was so much cheaper. So they went down that route and the state approved these. So medications used by the EMT, the state department and medical director will define which medications you're carrying on an ambulance. So again, make sure that you refer back to your state protocols and also local directives. So some oral medication advantages are ease of access and comfort level. Some disadvantages, obviously the digestive tract can be easily affected by food, stress, and illness. So the speed of movement of food through the tract dramatically changes the speed of absorption, right? So you just got to remember how that's working, how these medications work. With these, you want to confirm that the patient has a patent airway and is able to swallow. So if you give a patient oral glucose and they can't swallow on their Alter and they choke on that or they aspirate into their lungs, now we've caused more damage. And keep in mind, now we have the sugary gel that is now inside their airway, into their lungs, right? Sugar does not belong inside of there, at least not outside the bloodstream. So take standard precautions as far as following these steps. Standard precautions, confirm the medication is not expired, obtain medical direction per local protocol, okay? We're going to confirm that the patient has a patent airway and is able to swallow. And then, after all this is done, instruct the patient to swallow or chew the medication. What we want to also do is monitor the patient's condition. We need to document. So remember I talked about in your documentation portion of the program is that we have our primary, secondary assessment. We take our vitals. We document all this stuff, right? Then we have that reassessment. This is where that reassessment comes into play because you want to make sure you reassess the patient for any intervention that you have done to make sure the patient is either getting better or are they getting worse, right? And we have to monitor them. Vital signs every 5 for unstable, vital signs every 15 for a stable patient. Activated charcoal. Many poisonings involve overdoses taken by mouth, okay? Activated charcoal reduces the amount of medication being absorbed by the body by binding the drug to its surface absorption. Activated charcoal is ground into a very fine powder to provide the greatest surface area for binding. If allowed by protocol, you will carry a container with a pre-mixed suspension of activated charcoal powder and water. Activated charcoal is frequently suspended with sorbitol, which is a sugar, which has a laxative effect that causes the medication and the charcoal to move quickly through the digestive system. Administered by mouth may be unappealing to patients, so a covered container. So use a covered container and ask the patient to drink the fluid through a straw. Okay. Keep in mind that charcoal may stain, so use protective clothing over your uniform. We want to make sure we protect the patient's clothing and should not be given to a patient who has altered level of consciousness or risk for aspiration or have ingested an acid, an alkali, or a petroleum product. The last thing you want is for that to come back up through the airway and burn the airway or push it back through a laxative effect and have it burn the colon, okay? So we got to make sure we use this as directed, okay? Oral glucose is a sugar that cells use for energy. And we treat hypoglycemia with this. It can only be given by mouth. All right. And we do not want to give this to an unconscious patient or one who cannot protect their own airway. As an EMT, you can give oral glucose only by mouth and is available as a gel designed to spread on the mucous membranes between the cheek and the gums. It's not as quick as injections for hospital personnel, EMTs, and paramedics. Also available as glucose tablets. We never want to administer an oral medication to an unconscious patient. Remember, if they cannot protect their own airway, this could actually be more detrimental to them. All right, aspirin reduces fever, pain, and inflammation. Inhibits platelet aggregation, useful during heart attacks. So the purposes behind aspirin: antipyretic effect, which is reducing fever reducer. Analgesic effect, reduces pain. Anti-inflammatory effect, reduces inflammation. When it inhibits the platelet aggregation, which is useful during potential heart attacks, it prevents clumping. So if you think of platelets going through the system, okay, and what's happening is that, let's say your fingers are reaching out trying to grab stuff, okay, grabbing other platelets coming through. It makes the end of your fingers less sticky, so the platelets will then bypass that clump to prevent further clotting. It's not a clot buster. It is not a blood thinner. It just makes platelets less sticky. Contraindications to this would be hypersensitivity to aspirin, pre-existing liver damage, bleeding disorders, or asthma. Aspirin administration can trigger an asthma attack, and we should not be giving this to children. The term of baby aspirin needs to be taken out of your vocabulary. We do not give it to babies. We do not give it to infants. The new name for it, we're going to change the culture here, is low dose aspirin because it's 81 milligrams per tablet. All right. You can actually, under the age of 18, giving aspirin to a under the age of 18 person can actually trigger Reye syndrome. Sublingual medication advantages, obviously easy to advise patients, and it's a quick absorption. Remember I mentioned underneath the tongue, it's very vascular, right? So it's easy to talk with an awake and alert patient and advise them to place it underneath their tongue. The head and face receive large amounts of blood flow, so absorption rates are relatively quick. The disadvantages behind these: any medication placed in the mouth requires constant evaluation of the airway. You got to make sure that they don't swallow it. They do not chew it, let it dissolve underneath the tongue. They also must be alert to any signs of choking on a pill and should not be used if the patient is uncooperative or unconscious. Nitroglycerin relieves angina pain in cardiac patients. It increases blood flow and relaxes the veins. Keep in mind, when you're increasing blood flow, right, by relieving the spasm causing arteries to dilate, by relaxing muscles of the coronary arteries and veins. So as we're dilating, we're decreasing blood pressure. So that's going to be one of the side effects behind it. Remember that it also relaxes the veins throughout the body so that less blood is returned to the heart, decreasing the workload and decreasing the blood pressure. We do not want to have a high workload on these patients because, again, their heart is struggling. It requires that oxygen, that need. So before administering, we got to check a blood pressure. And these are ones we have to obtain medical control orders to administer. Possibility of an MI or myocardial infarction if there's no relief. This should not be used with erectile dysfunction meds. It may cause a mild headache. So even if a patient who has adequate blood pressure should sit or lie down with the head elevated before taking this medication to avoid fainting or a syncopal episode. If significant drop in blood pressure occurs, the patient will feel dizzy or sick. Lie them down flat, right? Make sure you get orders. If nitroglycerin no longer brings relief to a person for whom it has previously worked before, the patient may be experiencing an MI instead of an angina attack. So you want to ask how much nitroglycerin the patient needed in the past to relieve pain and how much was taken at that time. Report this information to medical control. If you have potentially fatal interactions, you can have potentially fatal interactions with erectile dysfunction meds taken within the past 24 hours. So Levitra, Viagra, Cialis, these are all drugs for erectile dysfunction that may be used by both men and women. The effects behind this relaxes the muscular walls of the coronary arteries and veins, resulting in blood loss. Sorry, less blood, not blood loss, resulting in less blood returning to the heart, and decreases blood pressure, relaxes the arteries throughout the body, and often causes a mild headache or a burning under the tongue after administration. The headache is fine, right? And the burning of the tongue, that's normal. It's a normal side effect. Here's some things to take away with nitroglycerin. This is what makes me nervous with this. If the patient has a low blood pressure, and I'm talking like 110/70, okay, which is normal for us, if they're having active chest pain, it could be a right-sided heart attack. These patients have preload issues, right? So what we don't want to do is vasodilate because it can actually drop their pressures by 40 to 50 points, causing them to pass out and potentially go into cardiac arrest. So we got to keep that stuff in mind, okay, when we're dealing with these patients. Is it the right patient, the right time to administer these medications? If a patient is having chest pain and you say, oh, well, they have to have nitro and aspirin, but they have, let's say, right-sided deficit, so they're maybe having a stroke. The last thing you want to do is give somebody having a stroke nitro, because if it's an occlusive, if it's a hemorrhagic stroke in the brain causing that deficit, and you give a vasodilator, what do you think is going to happen to the brain? What do you guys think will happen? Will the bleed get better or will it get worse?
Will it get worse?
Absolutely. Absolutely, it'll get worse. You're going to make that bleed even worse in the brain, and then it's going to cause more negative effects later on. So if you got a patient with stroke-like symptoms of active chest pain, contact medical control. So these are administration by a tablet. Make sure you're wearing your BSI, okay? Sublingually under the tongue, so SL. You're going to feel this is where it dissolves. The patient should experience a slight tingling or burning sensation. If not, the medication may have lost its potency because of aging or improper storage. Nitroglycerin, whether it be in a liquid form or a tablet form, needs to be kept in the dark. Sunlight can actually make the medication lose its potency. Be sure to make sure the expiration date is on the bottle. All right. Make sure you always keep it in the original glass and the cap is screwed on tightly. What looks like a cotton in a container is actually rayon. Right. So real cotton in the container can absorb nitroglycerin, reducing its potency as well. Do not place medications in any other container and avoid any kind of light, heat, or air. Any drug storage concerns in the patient's medical history as well, and administered by meter dose spray if they have a spray. All right, that's not something you want to spray around the air. Remember, that can aerosolize and get into you. If you need to put one spray through, spray it into a towel first, and then do your second spray into the underneath the tongue, if need be. When we administer this, we want to administer underneath the tongue. Wait 5 minutes before repeating a dose, and you want to make sure you monitor vitals. Wear gloves and know the local protocols. Now, because we are in Maine, New Hampshire, they allow you now to obtain 12 leads. Okay, here's an important 12-lead tidbit. Before giving a patient nitroglycerin, please obtain a 12-lead prior to medication administration. Aspirin is fine. Nitro, hold off until you get a 12-lead, right? Because there may be a rhythm on that EKG that the paramedic has to see that will dissipate or go back to normal if you give nitro, okay? So we want to see it pre and post medication administration. So Nick, I saw you repeat the term. Can you get online and let me know which one you're talking about?
You said in Maine and New Hampshire, you need to obtain a, was it a 12?
12 lead EKG.
Okay.
Electrocardiogram,
Okay.
which you will be trained on. It's part of your scope of practice module we're going to be doing in one of our in-person classes.
Okay, great. Thanks.
Yep. So we get that 12 lead EKG pre and post. And when you guys do your clinical rotations, you're going to see 12 leads being done. And it's a very big diagnostic tool that we utilize. Closely monitor the patient's vitals, particularly the blood pressure when you're giving nitrates, right? Give repeated doses per medical control and or local protocol. You need to contact medical control to get your orders for this. Always wear gloves, as this medication can be absorbed through your skin. You want to reconfirm if the medication is still indicated for the patient, and know and understand your local protocols. So when you get hired at a company, when you're doing your ride time or your precepting time, they should be going over with you the local protocols of that service to get you prepared to be able to work as a partner with somebody else for that company. It's all part of the preparation phase. Intramuscular medications, advantages, a quick, easy access without using a vein, and it's stable blood flow to the muscles. So considerations would be advantages, provides a quick, easy access. The blood flow to the muscles is relatively stable, even during circumstances of severe illness or injury. The disadvantages, it needs a needle, and there's subsequent pain as well. Patients may fear pain or injury with this, so you have to make sure we're administering this right. We have to make sure. I'll show you guys how to do IM injections for epinephrine use during one of our in-person practical days. Epinephrine controls a fight or flight response. Remember that we mentioned the parasympathetic, sympathetic nervous system? You guys remember that from A&P a little bit? Yes, no, yeah, awesome. So this medication, epinephrine, is what they call a sympathomimetic, right? Which mimics the effects of the sympathetic nervous system. Each nervous system, whether it be sympathetic or parasympathetic, has something called a neurotransmitter, right? Which helps stimulate that, the hormone that controls that fight or flight body response. So remember last time I mentioned that if I went up to Sean and I punched him in the face, he has a choice to make. Either he's going to fight me or he's going to run away. I'm going to pick on him because he's not here. I don't think he's here right now. All right. So with that being said, epinephrine, adrenaline is being introduced into your system. We can also administer that as well for patients who are in anaphylactic reaction, anaphylactic shock. The primary medication delivery for this is intramuscular, also called adrenaline, releases inside the body under stress. We talked about the neurotransmitter. Primary medication that the EMT will deliver. And then, like I said, this is sympathomimetic, so sympathetic mimic. It mimics the sympathetic system by giving an outside source neurotransmitter, epinephrine. Does that make sense? Perfect. All right, awesome. Again, if you guys have questions after the fact or want me to kind of go more in depth on this, I can with you. Just like I said, I'm giving you guys the highlights and a little bit of detail behind it. So remember with epinephrine, think about mimicking and simulating the sympathetic nervous system, fight or flight, right? If that's happening, we're going to have increased heart rate and our blood vessels are going to start to constrict. We want vasoconstriction. We're going to see that rapid heart rate, right, to help reduce some of the inflammation, for an anaphylactic type reaction. So the effects, increasing heart rate, constricts blood vessels, causing increased blood flow, increased blood pressure. It dilates passages in the lungs, easing the breathing problems in an asthmatic or an allergic reaction. This also may maintain blood pressure, allergic reaction, and should not be given to patients who have hypertension, are suffering from hypothermia, are experiencing a myocardial infarction. Remember, they're having a heart attack. We don't want to give them epi. That's what we want to do is speed up their heart. do not show signs of wheezing or airway obstruction due to allergic reaction. And then administering epinephrine by injection permitted in some states, which some states is New Hampshire, which is also Maine. And we have it at the EMT level. We are using this to treat life-threatening anaphylaxis. If they get stung by a bee, right, and they have a local reaction around the arm, and there's no respiratory compromise, no angioedema, then we're not going to give epi to these patients. If we have respiratory compromise, wheezing, hypotension, low blood pressure, these are the patients that need epinephrine and need it quickly, right? That's going to be our indications for it. Allergens cause a body to over-release histamine, right? So it's used to treat that. Insect venom or other allergens cause the body to over-release histamine. We have histamine receptors. We have 3 different histamine receptors within our body. By this over-release of histamine, we reduce blood pressure, causing wheezing from the bronchial spasm and swelling of the airway tissue, which would be edema. Swelling of the tongue, medical term, is called angioedema, right? Which makes it difficult for the patient to breathe, speak, swallow, and things like that. So epinephrine acts as a specific antidote to reverse the effects of histamine by constricting our blood vessels, allowing blood pressure to rise and reducing swelling, which then dilating the air passages to increase flow of air. Epinephrine may also be dispensed from an auto-injector, which not a lot of services carry anymore due to cost. So they've gone to the ready check inject kits, right? Automatically, so back to auto-injectors, they automatically deliver a preset amount of medication. Here are the dosages you guys need to know, right? 0.3 milligrams for an adult, 0.15 milligrams for a pediatric. If you look at the numbers, it's half the adult dose, right? Please do not give more than that, 0.3 or 0.15. And because we're using ready check inject kits, you have to draw that up into your own syringe. So you have to understand the med math behind it. When we do our in-person lectures, when we talk about ready check inject epinephrine administration, we will cover that. We're going to be administering this into different fruits and things like that to kind of prepare you for high-end injections. Yeah, Deb, I can do that again. The adult dose is 0.3 milligrams. That's the adult dose. Make sure you put the 0, the decimal point, and the 3. Not 0.3, because that can be confusing, right? The pediatric dose is 0.15 milligrams. This will cause a burning sensation. Yeah, thanks, Nick. 0.3, exactly. I put down mg next to it per milligrams. Remember, the amount of medication, if you put down mcg, it's micrograms, g is grams. Okay, that's a whole different setup, right? That is correct, Deb, 0.15 milligrams. So with this will cause a burning sensation where it is ejected. This will increase heart rate. Remember, it's a pathomimetic response. And some services do not permit EMTs to carry epinephrine, but do allow them to assist patients administering their own. New Hampshire and Maine allow you to administer. And it's a standing order. It's not medical control. All right, Narcan. Administering naloxone by injection. Okay, used to reverse the effects of an opioid or opiate overdose. These can be administered by family members or caregivers to help reverse dangerous side effects of opioid or opiate overdose, such as life-threatening respiratory depression. Some important considerations. Consult medical control to determine if the EMTs are allowed to administer. Yes, we can. However, you need to contact ALS support, okay, because Narcan can wear off. And if the patient remains unresponsive and we need to make sure we secure an airway, they may require paramedic care for intubation, right? They also might need IV access as well, and IV naloxone versus intranasal or intramuscular. Find out if the naloxone has been administered by a bystander prior to arrival. If the effects of the naloxone may not last long, as those are the opioids. Remember, opioids are longer lasting versus opiates, like fentanyl being an opiate versus an opioid. Fentanyl wears off over a faster period of time. Repeat doses may also be necessary. So these can cause several withdrawal symptoms, including seizures and cardiac arrest. That's why it's so important that when we give Narcan, we do not wake these patients up. Keep them unresponsive, but give them enough to maintain their respiratory drive. These can cause severe withdrawal symptoms. Consider your safety, as patients may become violent following a naloxone administration. And begin administering naloxone in increments of 0.4 milligrams, right? And then gradually increase based on the patient's response or lack thereof response. So once again, naloxone, 0.4 milligrams. All right. The most common technique for naloxone is intranasal, as you can see here. So we take it out of the syringe, or we draw it up, and we push it through a nasal atomizer. We shove that up into their nose and we push. What that does is aerosolizes it and gets into the mucous membranes of the nose. Oxygen, remember, all cells need it to survive. Remember, we talked about 3 things the body needs to stay alive, right? Blood sugar, oxygen. Without that, patient dies. By far the most commonly administered med in the pre-hospital setting. All cells need these, especially those in the heart and brain need oxygen to function properly. What you'll notice in patients that are hypoxic will start showing signs of altered mental status. Oxygen should be administered when a patient is not breathing or is having trouble getting air. Generally administered by a non-rebreather mask, which is 10 to 15 liters per minute. Again, things you guys need to know for these, okay? So non-rebreather of 10 to 15 liters per minute. And then a nasal cannula is 2 to 6 liters per minute. And you also need to understand the percentages behind these. All right. So a non-rebreather can administer up to 90% oxygen. All right. So 90 to like 99% oxygen for a non-rebreather. A nasal cannula can give you between 22 to 44% oxygen. And that's it. And some patients may be all they need is just enough for a non-rebreather. Enough for a nasal cannula. But if you're not tolerating the mask, then we can switch over to nasal cannula as well. Oxygen flows through two small tube-like prongs that fit in the patient's nostrils and can provide up to 44% inspired oxygen. When these are being administered, please make sure there are no open flames, lit cigarettes, or sparks in the area. Remember, you are administering oxygen. Oxygen does not catch on fire, it enhances fire. Okay? So if you have a flame near it, it enhances that flame, causing for more fire and more body surface area to become burned. MDIs and nebulizers, liquid turned into a mist or spray, as you can see in the picture here on the screen. Right? All right. These are used to administer liquid medications that have been turned into a fine mist by a flow of air or oxygen. These can be run through medical air or oxygen to administer these medications. Medication then becomes atomized and breathed into the lungs and delivered into the alveoli, where this will help with that bronchodilation, allowing for that better gas exchange. The advantage to this would be blood flow to the alveoli is very high, and absorption rates are very close to those found in IV medications. It's fast and relatively easy to use, commonly used because of convenience and portability. The disadvantages, the patients need to be cooperative and control their breathing. If they're unconscious, it cannot be used, and as an EMT, you could use a nebulizer for more severe problems. Nebulizers are the picture that you see on the screen. Medications administered using an MDI or small volume nebulizer usage for respiratory conditions that are not severe enough to require epinephrine. Chemical cousins of epinephrine are more narrowly focused on the lungs. They're delivered with an MDI or small volume nebulizer, and an MDI requires a great deal of coordination to be administered. That is correct. They do have a pretty cool mask for kids that attach to them as well. I don't know if they have any. You'll probably see more of those in the pediatric section, but they have like dinosaur masks and everything else, and bear masks and whatnot to help the kids keep them on. So a lot of times with these medications, I'll have something called a spacer, and that's what you're going to see in this device here. This is called the spacer here. That allows the patient to administer the medication into the spacer, and then allows them to breathe that in, so there's less chance of waste of medication. Small volume nebulizers, as you can see here, it requires the patient to hold them up. Takes a little bit longer to deliver the med, which is good. We also have more medication in it. Requires an external air or oxygen source. A small volume nebulizer can also be more effective than an MDI in patients with moderate to severe respiratory distress. With this can also be used while a patient is on CPAP and during BVM ventilation. So they have adapters that can hook into these to allow it to be pushed in through CPAP or a BVM. These can easily be adapted into a normal breathing mask, so if the patient can't hold it, you can put it into a mask as well. And then when we get into airway management more in our practical sessions, I'll show you guys how all this stuff works. Okay. Assisting the patient with a small volume nebulizer, obtain medical direction for a protocol, confirm the correct medication and expiration date, confirm that the patient is not allergic to the medication, remember your sample history. We're going to add the appropriate medication dose to the nebulizer reservoir and assemble the device according to the manufacturer's instructions. We're going to connect the nebulizer machine to an oxygen tank or a medical air tank for 6 to 8 liters per minute. We're going to place the nebulizer in the patient's mouth and instruct the patient to breathe until the medication is gone. Usually it takes about 5 minutes for this to work. Then we got to reassess the patient. Reassessment for this patient here requires lung sounds. Okay, so you want to make sure that you get lung sound administration. All right, sorry, lung sound check as well. All right, so it's been about an hour and a half. Why don't we take 5 minutes and come back? We'll come back at 7:30, and then we'll continue on. All right.
This conference will now be recorded.
All right, so small volume nebulizers. Like we talked about before, they take longer to deliver, but it's a higher concentration of medication that takes about 5 minutes. Right, but utilizing CPAP can definitely make a world of a difference. And I'm going to show you guys CPAP administration once we get more into respiratory emergencies and things like that. So patient use. So rescue inhalers or MDIs relieve bronchial spasms quickly. But again, it's a rescue inhaler as it states. Right, so it's not going to be utilized for long term. So examples would be like permanent mist, bronchade mist is another one. These are all cousins of epinephrine that produce fewer side effects. They act on more specifically than epinephrine on bronchi of the lungs, causing dilation with lesser effect on the heart. Even still, though, albuterol, Proventil, things like that, or Ventolin. Albuterol, you're going to see more of those beta effects, like on the heart, and beta effects on the lungs. So that stuff really doesn't go away. It's just something to pay attention to when you're giving these medications to patients, because you might see an increased heart rate. Respiratory patients may also use what they call a maintenance or a controller inhaler. These are more slow acting and meant to be taken regularly, like Pulmicort, Flovent disc, things like that are some examples of those. But there are dozens of different MDIs that are available. Again, you just got to figure out which one the patients are taking. As far as patient medications go, patient assessment includes finding out which medications the patient is taking. So part of your sample history, the M part, will be your medications. This provides vital clues to the patient's condition. It guides our treatment, how we're going to treat a patient in the field, and will be useful to the emergency department. So please make sure that you get this information from them. A lot of times they'll have like a medication list. The only thing is you want to make sure you go over that list with the patient in the back of the ambulance if they're stable enough to do so, to make sure that is a current medication list. And prime example, I had one patient the other day, and they had a med list of like 20 different medications on it, and not even a joke, a third of those they don't take anymore. But it's their current list. So I went through and crossed out the ones that the patient didn't take anymore, make sure that the hospital had an accurate medication list. Medication errors. With that, a medication error is an inappropriate use of a medication that could lead to a potential harm. This could include incorrect communication of a dose or administration of an incorrect dose as well. Remember I mentioned before putting a 0 in front of your decimal point? That's why it's so important, because someone could see 0.3 but not see that decimal point and think it's 3 milligrams versus 0.3 milligrams. That's why it's so important to make sure your decimal points and your zeros are in the correct places. Because 3 milligrams of epinephrine would actually kill somebody versus 0.3 milligrams, which would not. These are rules-based errors to administration of a medication that is outside one's scope of practice. If you are not allowed to administer it and medical control tells you to do so, you have to let medical control know, hey, I'm not within my scope. I cannot administer this. You let me to call for a higher level of care. Knowledge-based errors, choosing the wrong medication to administer. Skill-based errors, using incorrect equipment or incorrect procedure for administering the medication. If the circumstances of medication errors are understood, it may be possible to minimize them. So ensure that the environment does not contribute to the error. Insufficient lighting, organization of the equipment, limit distractions as much as possible. Consider using a cheat sheet to help yourself remember crucial steps to medication administration. Always ask yourself before you do anything, why am I doing this, right? Make sure you know why. There is an indication for what you are going to do, right? So make sure you have that in place. If you don't have an indication, then you probably shouldn't be giving it, all right? Because that could cause detrimental patient side effects and or could create you to have a major medication error, right? This kind of stuff can go to court. It could also end your EMS career. It could come after you if you kill a patient on a civil suit as well. So you got to keep this kind of stuff in mind. This is why it's so important to make sure before you do anything, why am I doing it? And does it make sense? And if you ever have any question on any kind of administration of a med, there's always medical control and call the doctor. If medication error does happen, provide appropriate patient care, call med control, let them know what happened, and you're going to follow local protocols. You need to document thoroughly, accurately, and honestly, and talk with your partner, supervisor, or medical director. The supervisors have to know, your chiefs have to know if there's a medication error, right? And you please do not lie about it, okay? Document what happened. All right, this provides opportunities to learn. It also identifies areas to target during quality improvement. All right, so let's go through review. Pharmacology is defined as the what?
B.
B. Perfect. Number 2, which of the following statements regarding medication is false? All right, correct, C. Number 3, which of the following routes of medication administration has the fastest effect? All right, B. Number 4, when administered to a patient, a metered dose inhaler will do what?
C.
So the correct answer would be A. A metered dose means that it's delivered the same medication each time you push down the drug. That's metered, it's set up for a specific dose every time. Number 5, you are managing a 62-year-old woman who's complaining of crushing chest pain. Her blood pressure is 84/64 and her heart rate is 110. Medical control advises you to assist her in taking her prescribed nitroglycerin. After receiving this order, you should do what? So I see a lot of you guys are putting down D. So I see question med control. Absolutely. So the correct answer is B. Repeat the patient's blood pressure to the physician and confirm the order. The blood pressure being that low is actually contraindicated for administering nitroglycerin because they're hypotensive, right? So if you know they give you an order, they may have not heard. They may have heard 184/64 versus 84. So repeat that blood pressure if they tell you that. You need to know, just because a physician gives you an order does not mean it's the correct order. Okay, that's why it's always good to repeat that and repeat the blood pressure and say, "Are you sure you want me to give this patient nitroglycerin? Their blood pressure is 84/64." All right, so B. Number 6, activated charcoal is indicated for patients who have ingested certain drugs and toxins because remember what activated charcoal does. All right, correct answer. The correct answer is actually D. Remember that charcoal, okay, being a very fine powder, binds to the chemicals in the stomach and delays absorption. And then also has sorbitol, which is a laxative to help poop it out. It'll actually be more diarrhea. The answer is D. Number 7, with regard to pharmacology, the term action refers to nice. All right, D it is. Number 8, which of the following patients is the best candidate for oral glucose? All right, good. Everybody got A. A. Oral glucose, diabetic patients, and you have to have a patent airway and able to swallow. Unconscious or altered mental status should not be receiving anything by mouth. Number 9, epinephrine is given to patients with anaphylactic shock because of the effects its effects of what? What does epinephrine do? What is the mechanism of action behind this? So remember, epinephrine vasoconstricts and bronchodilates. Nitroglycerin vasodilates. So the answer is B. And number 10, the process by which medications travel through the body tissues until they reach the bloodstream is called. So going through the body tissue into the bloodstream. Excellent. And C it is. All right. I'm going to pause this really quick, and then we'll start with chapter 12 for shock.
This conference will now be recorded.
All right, so shock or resuscitation applies to fundamental knowledge of the causes of pathophysiology and management of shock, respiratory failure, arrest, cardiac failure, arrest, and post-resuscitation management. All right, and apparently I also can't do anything with texting either. Once again, it's closed itself down. Stand by a second. I gotta bring up the chat box again. There we go. Chat box is back up and running. All right, so definitions, terms, things you need to know. Shock describes a state of collapse and failure of the cardiovascular system. Another term for this would be inadequate state of tissue perfusion. All right, so in this chapter, we're going to describe the state of collapse and failure. In the early stages of shock, the body will attempt to compensate by maintaining homeostasis. Homeostasis is a balance of all systems in the body. As shock progresses, however, blood circulation does slow and eventually ceases. Shock can occur because of medical or traumatic events, whether it be a heart attack, severe allergic reaction, motor vehicle crash, gunshot wounds, and things like that. So it could be a medical and or a trauma. EMTs do respond to different types of emergencies to provide care and transportation. So you have to be constantly alert for signs and symptoms of shock because it's something that can be missed easily if you're not looking at the vital signs and everything else that are a part of it. Skin color and temperature, vitals, mechanism of injury that can be indications of that as well. So look at everything as a whole, okay, to be able to determine shock. Remember, kids can compensate shock for quite a bit of time, and then all of a sudden they do crash. And when they do crash, they crash rapidly. So perfusion is the circulation of adequate amount of blood that meets the cell's current needs. So the body, remember, is perfused via the circulatory system. The circulatory system is a complex arrangement of connected tubes, including arteries, arterioles, capillaries, venules, and veins. Right? These are two circuits in the body. There are two circuits in the body. The systemic circulation of the body and the pulmonary circulation in the lungs. The systemic circulation carries oxygen-rich blood from the left ventricle through the body and back to the right atrium. Right? So in the systemic circulation, as blood passes through the tissues and organs, it delivers oxygen and nutrients. Adequate perfusion is also important for the removal of waste products such as carbon dioxide, which is picked up from the blood cells as blood circulates through the organs and returns to the heart and lungs. So remember, organs, tissues, and cells must have adequate oxygenation or they will die. All right. So in cases of poor perfusion, each time you take a breath, the alveoli, which are microscopic thin-walled air sacs, receive supply of oxygen-rich air. Oxygen then diffuses through the walls of the alveoli into the bloodstream and attaches to hemoglobin circulating on red blood cells. If oxygen or oxygenated blood is not properly circulated, then cell death will occur. Diffusion is a passive process in which molecules move from an area of higher concentration of molecules to an area of lower concentration of molecules. So oxygen molecules move from the alveoli into the blood. Carbon dioxide moves out of the blood into the alveoli, whereas the majority of oxygen is carried to the tissues attached to hemoglobin. Carbon dioxide can be transported in the blood from tissues back to the lungs in 3 different ways. They can dissolve in plasma, they can combine with water in the form of bicarbonate, and they can attach to hemoglobin. Carbon dioxide waste products released from the cells that can combine with water also in the bloodstream to form a bicarbonate. Bicarbonate concentrations become higher and more carbon dioxide is produced and the blood moves back towards the lungs. Normal bicarb levels is between 22 and 26. That's your normal bicarb level. Right? Anything above it and below it can mean could mean a metabolic issue within the system based upon that and a pH. Once it reaches the lungs, the bicarbonate breaks down into carbon dioxide and water, and the carbon dioxide is exhaled. In cases of poor perfusion or shock, the transportation of carbon dioxide out of the tissues will become impaired, resulting in dangerous buildup of waste products that may cause cellular damage. So we started seeing changes in pH. Our normal pH in the body runs a little alkalotic. 7.35 to 7.45 is our normal pH level. If we have a change in pH and a change in bicarb, the patient becomes either metabolic acidosis or metabolic alkalosis. So they could be alkalotic with metabolic issues or vice versa. All right. Does that make, I know it's a little more in depth. Does that make sense to you guys a little bit? All right. See some yeses, a little bit. All right. So the pH stuff and all that's more towards the advanced EMT level, but I kind of want you to have an idea of how it kind of works. We can't have too much carbon dioxide. We can't have high levels of bicarb. Can't have low levels of each either. If you have a deviation, we're not in homeostasis. Without homeostasis, we start going into shock. Kind of the breakdown of that. So shock refers to a state of collapse or failure in the cardiovascular system that leads to inadequate circulation, like internal bleeding. Shock is used as an unseen life threat caused by a medical disorder or traumatic injury. To protect vital organs, the body will then direct blood flow from the organs that are more tolerant of low flow, such as the skin and intestines, to organs that cannot tolerate low blood flow, such as the heart, brain, and lungs. If these conditions causing shock are not properly addressed, death may occur. So by recognizing these signs and symptoms can minimize organ damage and definitely save a life. Remember that shock is life-threatening and requires immediate recognition and rapid treatment. To add to that, our body starts to shunt. Shunting means collapsing. Okay, so if you're in shock, your extremities are the least important. So you start shunting blood from the extremities to the core, where all your vital organs are located. That's why I mentioned before, the first organ to shut down is your stomach, because that's the least important part. Okay, that's why patients start becoming very nauseated anytime they're in shock. So the cardiovascular system consists of 3 parts. A pump, which is the heart, a set of pipes, which are the blood vessels and arteries that act on the container, and then the container, the contents of the container, which is the blood. So for firefighters in the room, the heart is your fire pump, the pipes are your hose lines, and the blood is your water. Pretty simple, right? So we've kind of already covered all this. Okay, so I'm not going to go in depth over the heart. Again, we've already covered this during A&P. But as you can see, blood has to go in, blood has to come out, and you have to have oxygenation. Without oxygenation, we can no longer function. So we have to be able to breathe in and out effectively, and our heart has to pump effectively. And if there's any deviation between the two, something's going to get pissed off. If something gets pissed off, our body is no longer in homeostasis, therefore causing us to become altered, causing us to become very sick. And there's other medical conditions or traumatic injuries that can cause patients to go into shock. We're going to cover those in a few minutes. So the three parts can be referred to as the perfusion triangle. Imagine that, another triangle to remember, right? So the heart pump function, as you can see here, damage to the heart by disease or increased or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. If you have a blood vessel issue or container function, right? If all the blood vessels dilate rapidly, the normal amount of blood volume is not enough to fill the system to provide adequate perfusion to the body. Patients like sepsis, you can see widespread vasodilation. All right, heart pump issues like cardiogenic shock or blood content function if there's not enough blood, like hypovolemic shock. Right? So when a patient is in shock, one or more of these three parts are not working properly. Do they have wide systematic vasodilation from an infection? Are they in cardiogenic shock where the heart is no longer pumping effectively? Or are they bleeding out somewhere causing hypovolemic shock? Either way, we're not getting perfused. Blood pressure is the presence of blood within the vessels at any moment in time. Systolic blood pressure, remember, is the peak arterial pressure. Okay, so again, pressure generated every time the heart contracts. So in motion, diastolic pressure is the pressure maintained within the arteries while the heart rests between heartbeats. So pulse pressure is the difference between a systolic and diastolic pressure. So systolic, diastolic is your pulse pressure. It signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 may be seen in patients with shock. So systolic minus diastolic equals your pulse pressures. You guys got that? Systolic minus diastolic equals pulse pressure. Less than 25 is critical patient, all right? Take notes, you're probably going to see this again. Right, awesome. Blood flow through the capillary beds is regulated by capillary sphincters, which are circular muscular walls that can constrict and dilate. These sphincters are under the control of the autonomic nervous system, which regulates involuntary function, such as sweating and digestion. Capillary sphincters also respond to other stimuli, such as heat, cold, the need for oxygen, the need for waste removal. Keep in mind, all right, that under normal circumstances, not all cells have the same need at the same time. Like the stomach and the intestines have a high need for blood flow during digestion. But when they're not digesting, they don't need that high blood flow. Perfusion requires more than just having a working cardiovascular system. You have to have adequate oxygen exchange in the lungs. You have to have adequate nutrients in the form of glucose in the blood. You have to have adequate waste removal, primarily through the lungs. Like I said before, three things for the body to survive. You have to have sugar, blood, oxygen. Remove one of the three and the patient dies. They go into shock. Mechanisms are in place to help support the respiratory and cardiovascular system when the need for perfusion of vital organs is increased. These mechanisms include the autonomic nervous system and hormones. Hormones are triggered when the body senses that the pressure in the system is falling. The sympathetic side of the autonomic nervous system, which is responsible for the fight or flight response, will assume more control of the body's functions during a state of shock. This response is by the autonomic nervous system causes the release of hormones such as epinephrine and norepinephrine. Remember, we talked about neurotransmitters. Hormones cause an increase in heart rate and in the strength of cardiac contraction and vasoconstriction in non-essential areas, primarily in the skin and GI tract, which we call peripheral vasoconstriction. They are triggered, hormones are triggered when the body senses that the pressure in the system is failing, starting to fall. All right? All right, move forward here. Together, these actions are designed to maintain pressure in the system and sustain perfusion of all vital organs. And it is a response that causes all these signs and symptoms of shock. So some causes of shock. Shock can result in many conditions, including bleeding, respiratory failure, acute allergic reaction, and overwhelming infection. So sepsis, like a distributed type of shock like that, systemic shocks. In all cases, the damage occurs because of insufficient perfusion of organ and tissue. So let's talk about pump failure. The causes of pump failure are heart attack, trauma to the heart, or other kinds of obstructive causes. The different types of shock are cardiogenic shock or obstructive shock. Under obstructive shock, you can have tension pneumothorax, cardiac tamponade, and a pulmonary embolus. Poor vessel function causes infection, drug overdose, spinal cord injury, and anaphylaxis. And there are two different types of shock with this. There's distributive shock, which is septic or neurogenic, anaphylactic or psychogenic. All right, so those four distributive types of shock underneath this section, okay? Septic, neurogenic, anaphylactic, psychogenic. With that being said, you'll have low fluid volume as another one. Causes of this could be trauma to the vessels or tissues, fluid loss from GI tract, like vomiting, diarrhea, can also lower the fluid component of the blood. So you're going to have hypovolemic shock, which could be hemorrhagic or non-hemorrhagic. So if you're bleeding out hemorrhagic, and your non-hemorrhagic shock is going to be like vomiting, diarrhea, and infants can go into hypovolemic shock quickly because they have such a low body mass and low amount of volume. These patients, if they're having diarrhea or vomiting profusely constantly, over time, their body cannot replenish what has been lost. Right? So you got to keep an eye out for those. Again, these patients should be getting vitals every 5 minutes, monitoring heart rate and blood pressure and pulse oximetry. So the illustration you see here on the slideshow are the three basic causes of shock and impaired tissue perfusion: pump failure, low volume, and poor vessel function, which we've already covered. With pump failure, causes of this would be the heart attack, trauma to the heart, obstructive causes like large vessel pulmonary embolus, fluid volume, trauma to the vessels or tissues, fluid loss in the GI tract, vomiting, diarrhea can also lead to this as well. And then poor vessel function like infection, sepsis, drug overdose, narcotics, spinal cord injuries, anaphylaxis as well. As you can see here in this chart. Again, these charts are also in your ebook as well. These types of shock that you see on here are things you really need to memorize. One of the very commonly missed in the field is septic shock. Patients that have a known infection site, low blood pressure, are indications of severe inflammatory response syndrome. Right? So when we start getting into more of the shock stuff later on, we'll cover more of this in depth. So cardiogenic shock is caused by inadequate function of the heart or pump failure. Resulting buildup of pulmonary fluid is also called pulmonary edema. So a major effect is the backup of blood into the lungs. Patients that have pulmonary edema have left-sided heart failure, okay? Left side. Heart starting to fail, fluids coming in, has nowhere else to go, goes into the lungs, resulting in buildup of pulmonary edema. So this is what we call APE or acute pulmonary edema, or just pulmonary edema is perfectly fine as well, where we start doing buildup of fluid into the lungs. Edema is the presence of abnormally large amounts of fluid between the cells, causing in bodily tissue, causing swelling. Basically, they're drowning internally. Pulmonary edema leads to impaired respiration, which may be manifested by increased respiratory rate or abnormal lung sounds. So you're going to hear that crackly sound inside the lungs if you have pulmonary edema. And you're not going to have it just on one side. Acute pulmonary edema will be bilateral, so on both sides of the lungs. And you're going to hear fluid changes as it goes up, versus bronchi, which you'll hear that mucousy sound, and that might be more lobe specific, like a pneumonia. Cardiogenic shock also develops when the heart can no longer maintain sufficient output to meet the demands of the body. Cardiac output is the volume of blood that the heart can pump per minute, and is dependent on several factors. One, right? The heart must have adequate strength, which is largely determined by the ability of the heart's muscle to contract, which is called myocardial contractility. Number two, the heart must receive adequate blood to pump. And number three, the resistance to flow in the peripheral circulation must be appropriate. Obstructive shock is caused by a mechanical obstruction that prevents adequate volume of blood from filling the heart's chambers. Three of the most common examples are cardiac tamponade, tension pneumothorax, and pulmonary embolus. So let's talk about cardiac tamponade. Cardiac tamponade, which is a pericardial tamponade, is a collection of fluid between the pericardial sac and the myocardium. This is called a pericardial effusion. If the effusion becomes large enough, it can prevent the ventricles from filling blood in a condition called cardiac tamponade. It is caused by blunt or penetrating trauma causing hemorrhage around the heart. Excuse me. Cardiac tamponade occurs when blood leaks into the space between the tough fibrous membrane known as the pericardium and the outer walls of the heart in the area called the pericardial sac. As more blood and fluid accumulate in this confined space, the outer walls of the heart become compressed, right? And there are three things you look for to be able to determine cardiac tamponade. We'll go over that here in a second. The accumulated blood or fluid in the pericardial space eventually exerts pressure back onto the outer walls of the heart, compressing the walls of the heart to prevent the heart from completely refilling with blood. Remember, continued pressure within the pericardial sac obstructs the blood flow to the heart, resulting in decreased outflow from the heart. Signs and symptoms of cardiac tamponade are referred to as Beck's triad, B-E-C-K, Beck triad. Okay, you guys need to memorize this. You will see this again. It will come back to haunt you. Beck's triad. There are three things in Beck's triad. One, presence of jugular vein distension. So you're going to have distended jugular veins on each side of the neck. Number two, muffled heart tones, muffled heart sounds. So you listen to heart sounds, they're going to sound like they're muffled, all right? Last thing is number three, narrowing pulse pressures where the systolic and diastolic blood pressures start to merge. What they mean by that, blood pressure of 90/86. So your systolic and diastolic numbers are very close together. So I'm going to repeat that again. Beck's triad indicates cardiac tamponade, and you're looking for three things. That's why it's called a triad. 1, jugular vein distension. 2, muffled heart sounds. And 3, narrowing pulse pressures. All right. This will be a national question that you're going to see on your exams. Right? You guys got that?
Yeah.
So sorry, Nick, I just happened to see your message there. How do you check that? Which one are you talking about? The cardiac tamponade? I believe you were asking. So you're asking about pulse, like the pulse pressure, is that what you're talking about? Okay. So the pulse pressure, like Sean just mentioned here, systolic, diastolic blood pressure. If you take a blood pressure manually or on an automatic BP, if the systolic pressure and diastolic pressure are very close together in numbers, that's narrowing pulse pressure. All right. So again, three things to look for. Beck's triad, very important. Tension pneumothorax is caused by damage to the lung. So what happens here is the damage allows air normally held within the lung to escape into the chest cavity. The lung will then collapse, and if the pneumothorax is left untreated, air will start to accumulate in the chest cavity and apply pressure to the organs, including the heart and great vessels. Right? So tension pneumothorax, collapsed lung, air escapes in. And until that gets rectified and it's done with a paramedic level of care and getting to a trauma center. Paramedic care, needle decompression. Trauma center, they put in a chest tube. Needle decompression is short term. Chest tubes need to be placed, right? Patients need to go to a trauma center, and chest tubes usually applied by a surgeon. They usually go in through the fifth intercostal space, mid-axillary line. Pulmonary embolus is a blood clot that occurs in the pulmonary circulation that blocks the flow of blood through the pulmonary vessel. When a massive pulmonary embolus occurs, it can prevent blood from being pumped from the right side of the heart to the left side, resulting in complete backup of blood in the right ventricle and leading to catastrophic obstructive shock and complete pump failure. These patients with PEs, some of the signs and symptoms of these: multiple syncopal episodes. They're going to look like they have high anxiety. Okay, they're going to be bouncing around. They can't breathe. They're starting to panic. Right, shortness of breath. They're going to have chest pain, and this can happen in a 19-year-old. It can happen in an 80-year-old. It doesn't really matter. PEs can happen. One of the common indicators, or not indicators, one of the common precursors to pulmonary embolus is usually females that are on, I'll take a moment, my goodness, birth control. Right, that's why a lot of times when females are on birth control, they take like a daily aspirin as well to help make the clots, if there are any, less sticky or preventing from more clots happening. Right. So again, things to pay attention to. Just because they're 19 and they're very anxious and keep passing out does not mean it's an anxiety attack. It could be a PE. So put on your investigation hat and ask appropriate questions. Patients that travel long distances, that are in a sitting position, that do not get up and stretch and move around, can develop calf pain. Calf pain could be what they call a deep vein thrombosis that can free up and go into the lungs, causing a pulmonary embolus. Right? Other things would be like recent surgeries. Right? Sometimes it happens, and then clots are formed, and then they get released, and it goes into the lungs. All right. Distributive shock is a result of widespread dilation of small arterioles and small venules, or both. The circulating blood volume then pools in expanded vascular beds. Then, tissue perfusion decreases. This is where we start talking about septic shock. Even a paper cut on your finger could turn septic if not treated. This occurs as a result of severe infections in which toxins are generated by bacteria or by infected body tissue. Then what happens here is toxins that damage the vessel walls, causing increased cellular permeability, which then causes wide stem or systemic vasodilation and getting bacteria into the blood, which then named bacteremia, right? So the bacteremia then causes widespread vasodilation, causing blood pressures to drop. Now you're in a distributive shock because of a massive infection in the blood. Your vessel walls then start to leak and are unable to contract well, therefore it causes your increased respiratory rate, altered mental status, decreased oxygen saturations, low blood pressures with a MAP of less than 64. You could have temperatures well greater than 100.8, or less than 96.8 would be called cold sepsis, and these can lead into death. These patients usually are getting intubated and put on a ventilator, multiple antibiotics running, along with pressors to keep the blood pressures up higher. So these patients can become very sick if we miss the signs and symptoms in the field and start treating them and getting ALS on board to give them fluids. These patients here usually get 4, 5, 6 liters of fluid to help replenish that fluid loss, right? So widespread dilation of vessels in combination with plasma loss through the vessel walls resulting in shock, right? Basically, it's like a wide systemic vascular system hypovolemia. Neurogenic shock, usually the result of high spinal cord injury. Causes include brain conditions, tumors, pressure on the spinal cord, and spina bifida. So in neurogenic shock, the muscles of the walls in the blood vessels are cut off from the sympathetic nervous system and nerve impulses that cause them to contract. All vessels below the level of the spinal injury dilate widely, increasing the size and capacity of vascular system and causing blood to pool. The available 6 liters of blood in the body that can no longer fill the enlarged vascular system, and even though there is no blood flow or fluid loss, perfusion of the organs and tissues become inadequate, and shock occurs. Signs of this type of shock are the absence of sweating below the level of injury, normal or low heart rate in the presence of hypotension, and normal warm skin. So again, things we need to pick up on. Anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized to. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure after sensitization tends to produce more severe reaction. So there are people that, for example, For example, there are 4 categories of anaphylactic shock that include exposure to injections like tetanus, penicillin, stings, ingestions, or inhalation, like fish, shellfish, nuts, eggs, different meds. People that go all their life eating strawberries, all of a sudden, boom, they're allergic to strawberries. Medications, lisinopril is one of the biggest ones that people have an anaphylactic reaction to. They'll take lisinopril for so many years, and all of a sudden, they have a major reaction to it, full angioedema, airway swelling, and it's because they are just the medicine. This develops, allergic anaphylactic reactions can develop within minutes or even seconds after contact with the substance. There also may be a second phase reaction that occurs 1 to 8 hours after the initial reaction as well. So the signs are very distinct and not seen with other forms of shock. I'll show you guys in the next slide. Note that cyanosis, or the blue discoloration of the skin, is a late sign of anaphylactic shock. And the combination of poor oxygenation and poor perfusion anaphylactic shock may easily prove fatal. Anaphylactic shock requires quick administration of epinephrine. And then also paramedic level care, where we can get histamine blockers like diphenhydramine, and also other medications to help open up the airways. We carry other medications like MAC sulfate, solumedrol, and things like that to help assist. So if you got a patient anaphylactic reaction, don't think just epinephrine is going to work. It's temporary. You may have to give multiple doses, but we can do other as paramedics, we can do a lot more involved with that. So get ALS started, right? So they can do other medication administration. So as you can see on here. So urticaria is hives. Cyanosis, these are more your skin stuff, circulatory system. Dilated peripheral blood vessels, which you're going to see your drop in blood pressure. You may have a weak or barely palpable pulse because of the widespread vasodilation. You can see respiratory, and then obviously other symptoms like abdominal cramping, nausea, vomiting, things like that. Zofran, like antiemetics, the patient doesn't need that. What they need is to get their body back in homeostasis. All right, psychogenic shock, which is caused by a sudden reaction of the nervous system. So a patient in psychogenic shock produces a temporary generalized vascular dilation resulting in fainting or syncope. The fainting episode is temporary and the patient rouses usually soon after. Syncope occurs when blood pools in the dilated vessels, reducing in blood supply to the brain. As a result, the brain then ceases to function normally and the patient faints. Remember, it's important to realize that some of the causes of syncope are of serious nature, but others are not. So life-threatening causes include irregular heartbeats or brain aneurysms. Non-life-threatening events may include receipt of bad news, experiencing fear or unpleasant sights like the sight of blood. Life-threatening causes also include irregular heartbeats, and we talked about that, and brain aneurysms. So again, take a look at the patient, assess them, see what's actually going on, set of vital signs, get your rapid and detailed exams, and move forward from there. The result in inadequate amount of fluid or volume in the circulatory system is hypovolemic shock. There are hemorrhagic causes and non-hemorrhagic causes of this. Obviously, hemorrhagic being bleeding, non-hemorrhagic being like vomiting, diarrhea. Other hypovolemic shock also occurs with severe thermal burns, like intravascular plasma is lost, and plasma then leaks into the circulatory system, into the burned tissue that lie adjacent to the injury. So that's why it's also very important to keep these patients warm, or even burn patients. Keep them warm because they can become hypothermic because they've lost their ability to thermoregulate because the skin layer is being gone. On top of that, we're also losing intravascular plasma. Therefore, the patient can become very hypothermic quickly. Dehydration is another one where the loss of water or fluid from body tissues can aggravate shock by severe vomiting or diarrhea. The patients need fluid replacement. Also, by diarrhea and vomiting as well, can also deplete nutrients that are needed and electrolytes. Therefore, you may have different cardiac issues as well. All right, so cardiac abnormalities and EKGs. So a patient with severe chest injury, respiratory insufficiency, may be unable to breathe an adequate amount of oxygen. So severe chest trauma, COPD exacerbation, things like that. These can all cause the patient to become hypoxic. So anemia is the abnormally low number of red blood cells. So you're going to have a low red count. They also can be like low iron deficiency as well. Anemia may also be the result of either chronic or acute bleeding, which is a deficiency of certain vitamins or minerals or an underlying disease process. We cannot tell if the patient's anemic. Okay, we don't have that ability in the field, right? What they need is what they call a complete blood count, what they call a CBC lab draw. With that, they're going to look at hematocrit, hemoglobin, red cells, and white cells with those 4 things within a lab draw for that. And I'll give you numbers. And those numbers will indicate whether the patient is anemic or not. We'll also do like an iron check as well. Tissues may become hypoxic because the blood is unable to deliver adequate amounts of oxygen to the tissues. Even though the available hemoglobin is fully saturated with oxygen, as long as we're delivering enough oxygen to the blood, right? Other things that, remember, making a patient hypoxic would be like carbon monoxide poisoning being one of them, or cyanide, as you can see here. These may have the types of poisoning may also affect the ability of cells to metabolize, because carbon monoxide, cyanide, they can attach hemoglobin over oxygen. And even though your pulse oximeter reading still reads 98%, does not mean that they are perfusing appropriately. So we're going to have to treat these patients, and with carbon monoxide poisoning, they need 100% oxygen, non-rebreather, constant flow to flush their system. Unless they are very sick and unresponsive, then they need to be put on a ventilator. So the progression of shock, there's different stages. We have compensated shock. So in early stages of shock, the body can still compensate for blood loss. Signs and symptoms of this would be agitation, anxiety, restlessness, and the feeling of impending doom. Altered mental status, weak, rapid, thready, or absent pulse. Clammy, pale, cool, moist skin. Pallor or cyanosis about the lips. Shallow, rapid breathing. Air hunger, shortness of breath, especially if there is a chest injury. Nausea, vomiting. Cap refill longer than 2 seconds in infants and children. Marked thirst. Narrowing pulse pressures. Right? That's your compensated shock. Your decompensated shock, the late stage, when blood pressure is falling, signs and symptoms would be falling blood pressure, systolic blood pressure of 90 or lower, labored or irregular breathing, ashen mottled cyanotic skin, thready or absent peripheral pulses, dilated pupils, dull eyes, poor urinary output. And when shock has progressed too far, it's called irreversible, and there's no way to assess when the patient has reached this point. It is imperative to recognize and treat shock early, because well before the patient transitions into the decompensated phase. Right? So again, we have to catch this in compensated shock and start treatment. Irreversible is irreversible. It means they're going to die. There's no way around it. So here are your signs and symptoms here for progressive shock, or progression of shock from compensated to decompensated. All right. We're going to finish up 2 more slides, and we're going to take 5 minutes, come back, and we'll finish up the lecture. So the progression of shock, blood pressure may be the last measurable factor to change in shock. So when a drop in blood pressure is evident, shock is well developed. So you got to pick up on your tachypnea, so your faster respiratory rate. You got to pick up on the tachycardia, right? These are more earlier signs. But if you start seeing blood pressure changes, okay, now we're starting to get into the decompensated phase, right? This is the particularly true in infants and children who can maintain their blood pressure until they have blood loss that is more than half their blood volume, half, all right? By the time blood pressure drops in infants and children who are in shock, they are close to death. So expect shock in many emergency medical situations. All right, so progression. Also expect shock in the patients if they have any of the following conditions: multiple severe fractures, abdominal or chest injury, spinal injury, any severe infection, a major heart attack that can cause cardiogenic shock, anaphylaxis. All right, let's take 5 minutes. We'll come back at 8:40 and we'll finish up.
This conference will now be recorded.
So let's talk about the actual assessment portion of this. So scene size up. Again, be alert for potential hazards for your own safety, okay? BSI, scene safe, scene size. Use gloves, eye protection for trauma scenes where bleeding is suspected. Remember, you can have arterial bleed, things can be squirting everywhere, right? So again, protect yourselves. If incidents involving violence, make sure PD is on scene prior to you getting there. Make sure that the scene is safe. All right. So with your primary assessment, we're going to perform a rapid exam. Remember, head to toe, 60 to 90 seconds. We're going to determine the level of consciousness and identify and manage any life threat concerns. Major bleeding. If you need to put a tourniquet on, put a tourniquet on, move forward. All right, if you've got to clear ABCs, clear ABCs, airway, breathing, circulation. All right, determine the priority of the patient, and then we got to determine transport. A patient with a massive hemorrhage may require a tourniquet or direct pressure dressing when tourniquets are not feasible or available before the airway is actually open. Again, if they are bleeding out, they will die if you do not stop the bleeding. If the patient has a life-threatening external bleed, it should be addressed first, even before airway and breathing. Then ABCs can be addressed and treated. Provide high-flow oxygen to assist in perfumage of damaged cells or tissues. If the patient has signs of hyperperfusion, treat aggressively and provide rapid transport to the hospital. Request ALS as necessary to assist with more aggressive shock management. We then want a formal general impression. This will help you determine sick or not sick. Determine the need for manual spinal stabilization and assess the patient's level of consciousness using the AVPU scale. Alert, verbal, painful, and responsive. A patient who has an altered level of consciousness, LOC, may need emergency airway management. If the patient is awake and alert, determine a chief complaint. What is going on? What happened? Why did we call? Right? Airway breathing. Assess the airway to ensure it is patent and then quickly assess breathing. Observe the patient for signs of accessory muscle use, such as muscles of the neck, intercostal retractions, or abnormal use of the abdominal muscles. An increased respiratory rate is often an early sign of impending shock. So we want to make sure we assess for wheezing or any other abnormal breath sounds and administer high flow oxygen to assist or assist respirations with a bag valve mask. Circulation, we're going to assess patient's circulatory status. That can reveal important clues regarding the presence of shock, tachycardia being one of them. We're then going to check for a distal pulse. If there isn't one, then check for a central pulse. Distal pulse being radial, central being carotid. Determine if the pulse is fast, slow, weak, strong, or altogether absent. A rapid pulse suggests compensated shock. So in a shock or compensated shock, the skin may be cool, clammy, or ashen. Right? If the patient has no pulse or is not breathing, we begin CPR. We want to make sure that we're assessing, identifying any life threat bleeding in trauma patients. If serious bleeding is discovered, treat it at once. Right? You must also be quickly assess the skin temperature, condition, and color, and check for cap refill. We're going to determine whether the patient should be treated as high priority, whether ALS is needed, and which facility to transport to. Follow local protocol. Trauma patients with shock or suspicious of MOI generally should go to a trauma center. Again, know your local protocols. History taking, we're going to get a sample history and determine the chief complaints, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading to injury or illness. Then we're going to get our secondary assessment. It begins by repeating the primary, followed by a focused assessment if needed to a focused. If a life-threatening problem is found, treat it immediately. Obtain a complete set of vital signs, baseline vitals, and then every 5 to 15 minutes based on stability. We're going to reassess the patient looking at vital signs again every 5 to 15 minutes. We're going to reassess our interventions. If we apply a tourniquet, make sure the tourniquet is still stopping blood flow. If we apply an oxygen, we want to make sure that they're not cyanotic anymore, that they're getting better skin color, better temperature, warming the patient up by putting blankets and heat packs. Okay? We're going to reassess the chief complaint, because if something starts getting better, something else may get worse, or the pain from one may mask the pain from another. Reassess ABCs, because the airways can change, breathing can change, circulation can change. And then look at our mental status. Determine what interventions are needed at this point and the reassessment. Do we need to do another intervention? We're going to focus on supporting the cardiovascular system, okay? Shock patients need to be laying down flat. We need to provide oxygen, and we need to keep them warm. We got to wrap them up. You need to make it so uncomfortable for yourself, heat-wise, in the back of an ambulance. That means that you're doing a good enough job keeping the patient warm. As soon as you recognize shock, begin treatment. Follow standard precautions. Control obvious bleeding. Place a dry sterile dressing over the bleeding sites and secure with bandages. If direct pressure is not rapidly successful in controlling the bleed from an extremity, apply a tourniquet. Make sure the patient has an open airway to maintain manual inline stabilization if necessary. Then you can apply your cervical collar and check for breathing and pulse status. As soon as you recognize shock, begin treatment. Calm, comfort, and reassure the patient. Never allow patients to eat or drink anything prior to being evaluated by a physician. If they eat and drink and they have to go to surgery, they can't perform that surgery, okay? So you gotta make sure there's no, food, no drinking in the back of the ambulance, even before you transport. It says put the patient on a backboard. We do not use backboards in New Hampshire anymore, but the national scope still uses backboards. Provide oxygen and monitor the patient's breathing. As soon as you recognize shock, again, place blankets under and over the patient. Remember, heat still transmits down. So if your body is on a cold surface, that heat is still going to be dragged out of your body, okay? So wrap the blanket. So if you're using a backboard for an extrication purpose, then put padding underneath and warm and blankets to keep the patient's heat inside. Right? Nothing by mouth, and accurately record patient's vital signs approximately every 5 minutes throughout treatment and transport. Right? The patient cannot generate the power to pump blood throughout the circulatory system. This is cardiogenic shock. Right? Chronic lung disease can aggravate cardiogenic shock as well. So the patient is often able to breathe better in a sitting or semi-sitting position, so Fowler, semi-Fowler. Usually patients with cardiogenic shock do not have any injury, but they may be having chest pain. The patient may have taken nitroglycerin before EMS arrived and may want to take more. Patients in cardiogenic shock should not receive nitroglycerin. By definition, they are usually hypotensive. Patients will usually have low blood pressure, weak, irregular pulse, cyanosis about the lips underneath the fingernails, all right? Anxiety, nausea. So you want to place the physician in a position that eases breathing as you give high flow oxygen. So what position of comfort? Assist ventilations if you need to. Provide prompt transport. Consider meeting ALS en route to the hospital. And provide calm reassurance for the patient with a suspected heart attack. Right? If you are anxious, that patient becomes more anxious. If you're freaking out, the patient starts freaking out. The more stress on that you show, the more stress the patient will then start receiving. Therefore, it puts more stress on the heart. So we got to make sure we remain calm. For cardiac tamponade, increased cardiac output is the priority. Okay, so apply high flow oxygen. The only treatment is surgery. Another thing they can do is pericardial centesis, which is a long needle they stick into the pericardium and they pull that fluid out. That is not a skill a paramedic can even do in these states. It's an advanced skill rarely performed in the field. The only one that I know about that does this is Health Net, which is the critical care medics from UVM Medical Center in Vermont that I know about that does pericardiocentesis in the field. Usually these are ultrasound guided as well. So for tension pneumothorax, we're going to apply high flow oxygen to prevent hypoxia. Usually the only action that can prevent eventual death in tension pneumothorax is a decompression of the injured side of the chest. So chest decompression is a paramedic skill. So get them going early, or do not delay transport. So if you have a patient with a tension pneumothorax on scene, get them in the ambulance, get them transported to the hospital, meet the medic en route. Ultimately, they're going to get a chest tube, right? So the paramedic decompression is more of a temporary fix, but still a fix this patient needs. But don't wait on scene for it. Treating septic shock, again, hospital management is needed. These patients need antibiotics to start treating that infection and fluids, and potentially airway management, right? Use standard precautions, administer high flow to ventilate support. Ventilatory support may be necessary with this. We're going to keep the patient warm because remember, even though they are hyperthermic or a higher temp, they can go in what they call cold sepsis. These are patients you want to alert the hospital as a sepsis alert so they can get their sepsis team available if they have one ready. A lot of things need to happen. There's a lot of setup for sepsis patients coming in, including more IV access and everything else, along with pulling multiple blood tubes and culture tubes as well. Right. So a lot needs to happen with these patients. So giving them a heads up early, they can start prepping. Treating neurogenic shock for the spinal cord injury patient, use a combination of all known supportive measures that you have. The patient who has sustained this kind of injury usually will require hospitalization for a long time. Treating it in an emergency situation, obtain and maintain a proper airway, provide spinal mobilization. We're going to assist in adequate breathing as needed through a bag valve mask. Apply heat packs, conserve body heat, ensure the most effective circulation possible, keep patient warm, and transport to a facility capable of managing spinal injuries. Anaphylaxis, we're getting close to the end here. Administer epi, which we talked about already. A patient who is aware of having specific sensitivity may carry an epi kit with them. If so, they may have already administered it. If he or she is unable to inject the medication, you may have to do so by local protocol. A mild reaction may worse suddenly, so be prepared. Monitor your patients. Psychogenic shock is an uncomplicated case of fainting. Once the patient collapses, circulation into the brain usually is restored by that point. If the patient does happen to fall, you want to make sure that you're checking for the injuries. And psychogenic shock can also worsen other types of shock that are currently available, that are currently within the system. If the patient reports being unable to walk after a fall, suspect another type of problem. Transport the patient, record all initial observations, and try to learn from the bystanders. If the patient was unconscious, you want to find out how long they were unconscious for, and if they complained of anything prior to passing out. All right. For treating this, for hypovolemic shock, so low volume, control all obvious external bleeding, keep the patient warm. If bleeding is not controlled, then control it with direct pressure or a tourniquet. Recognize the internal bleeding and provide aggressive support. We're going to secure and maintain an airway and provide respiratory support and transport as rapidly as possible. All right, respiratory insufficiency. A couple more slides. Secure and maintain the airway. Clear the mouth and throat of any obstructions, if there are any, whether you use the abdominal thrusts or CPR, if they're unconscious. Suctioning to remove mucus or vomitus or any kind of foreign material. If necessary, we need to provide bag valve mask ventilations and administer supplemental oxygen and transport. Remember that the EMT must use caution when caring for older patients. Older patients generally have more serious complications than younger patients. Although illnesses illness is a common complaint among older patients, understand that it is not just part of aging. Many older patients take numerous medications that either mask or mimic signs of shock. For example, beta blockers can lower patients' heart rates. So getting a medical history could show in a medication list that they're on a beta blocker. If they are and they're in shock, normally what we'll see in shock is a tachycardia, but if they're on beta blockers, it'll mask that and show a normal heart rate. So just be aware of that. Look at their medical history and look at their medications. All right, let's go some review and we'll call it a night. The term shock is mostly accurately defined as A, B, C, or D. Can everybody hear me? I just saw a message saying that they had no sound. All right, I'm seeing yes. Okay. All right, awesome. So I believe you guys put down what letters? D's, B, and D. All right, so the correct answer is B. All right, let's go to number 2. Anaphylactic shock is typically associated with typically associated with the correct answer is going to be A, urticaria. Urticaria, remember, is hives, which is typically associated with an allergic reaction, mild, moderate, and severe. All right, so take a look. Now, when you're assessing a patient with anaphylaxis, look for stingers as well. Another thing you look for urticaria is you got to pull their clothing off. You got to look in places they may not see it, on their back, their chest, on the upper part of the thighs, on the buttocks, right? So if you don't see it, oh, I just lost Joy's, but there you are. So how does that differ from the welts? So what you're going to see with urticaria, you're going to see the cool, clammy skin is with that, and then what you're also going to see is more of like smaller dots, or like they start becoming more widespread, and then they become very itchy as well for hives versus the welts. You're welcome. Number 3, signs of compensated shock include all the following except
I hear an ambulance backing in.
that you do. They just got back from their call for Memorial. Answer is D. All right. Number 4, when treating a trauma patient who is in shock, lowest priority should be given to the lowest priority. All right, C it is. Number 5, potential causes of cardiogenic shock include all the following except all right. Seeing C's, and C it is. Number 6, a 60-year-old woman presents with a blood pressure 80 over 60, has a heart rate of 110, mottled skin, and temperature of 103.9. She is most likely experiencing Perfect. Septic shock. Good job. Number 7, a patient with neurogenic shock would be least likely to present with neurogenic shock. This is a tough one. So the correct answer is C. Where the nerves that control the nervous system are compromised. Therefore, the nervous system is responsible for secreting the hormones epinephrine and norepinephrine, which increase patient's heart rate. All right. Number 8.
Kevin, I made it back.
Hey, welcome back. We're just finishing up the entire lesson.
I was wondering
But welcome.
if you guys are still on.
Welcome back. So 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120. And respiratory is 30. You should be treating this patient for. Seeing some D's pop up. Sounds like a plan to me. All right, number 9. A 33-year-old woman presents with a generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her BP is 70/50 and her heart rate is 120. In addition to high flow oxygen, the patient is in most need of epinephrine. Good job. And number 10, all the following are potential causes of impaired tissue perfusion except perfect. A it is. All right, let me stop the recording. We'll have a quick discussion and we'll get you guys out of here an hour early.